Hello students. So today welcome to the image-based questions, that's IBQ sprint, which is conducted by Doc Tutorials. So in this session, we would be discussing very important and frequently repeated image-based questions and related points in ObGyn. So basically, I compiled it in such a way that we have included sessions. So I compiled it in such a way that the important questions from NEET, NExT, FMGE, and the image-based questions that has come from ObGyn are combined in this. So in this session, first I would be showing you the image, and if possible, try to comment what your diagnosis is. And then we would be discussing very important key points that is related to these images as well. So as the name suggests, this is going to be IBQ sprint where we quickly discuss the most important 20 images from ObGyn. So without wasting any time, let's go into the topic. So first, let's have a look at this image. What do you appreciate in this image? This is basically an HSG, that is hysterosalpingography. And in this image, you can appreciate that there is filling in the uterus. And on either sides, you can see the fillage through the tubes, and there is some spill which is present. This is the uterine contour which is there. And again, on the other side as well, you can see the tube. But what is marked in the image? You can see that there are filling defects which are present. There are filling defects which are present, and they are irregular filling defects. And these irregular filling defects are suggestive of, yes, it's Asherman. Okay, so I'll be just repeating the last part which we discussed once again. So let's start fresh from the first slide which we are discussing. So basically, we are discussing about Asherman syndrome. And in case of Asherman syndrome, there is adhesions between the uterine wall. The clinical features that can be associated include the patient can have hypomenorrhea and even amenorrhea. The most common risk factor is curettage, where we do a dilation curettage, and the periods when this can happen include in the postpartum period as well as in the post-abortal period. These are the high risk time where the adhesions can happen. In this condition, the investigation of choice, initially it is going to be HSG, that is hysterosalpingiography. But the gold standard investigation, that's the best investigation, the gold standard is basically hysteroscopy. And why is hysteroscopy the gold standard? Because I can treat the patient in the same setting. We can go for a hysteroscopic adhesiolysis. That's I can cut these adhesions along with hysteroscopy. So the investigation of choice is HSG. The gold standard investigation is hysteroscopy, and the management is hysteroscopic adhesiolysis. This Asherman syndrome is a very famous topic, and often they ask this HSG image where you see the irregular filling defects as it is seen here. Where do you see regular filling defects? Suppose you see a defect which is perfectly regular and round in the uterus, that can so the images are showing a septate uterus. Yes. So the images are showing a septate uterus and a biconvate uterus. So how do you differentiate between a septate and a biconvate? Often I get questions from students about this, how to differentiate these two types. So in case of septate uterus, if you see here, you can see that the intercornual distance is less compared to the other image. Here it is less than 4 centimeter, whereas in biconvate the horns are far apart. It is more than 4 centimeter. So in septate less than 4, biconvate it is more than 4 centimeter. The other differentiating feature between this is the angle which is seen between these uterine bodies. So here you can see that the angle is closer, it is acute. Whereas in the other one, the angle is more obtuse. It is obtuse in the other situation. So there is some problem with the screen. Can you please let me know if it is good? Can you see the screen? All right, okay. So let me just explain how to differentiate between a septate and a biconvate uterus. So let's just see how to differentiate between a septate and a biconvate uterus. So in septate uterus, as you see here, if you see at both the cavity which is seen here, it is closer together. Whereas in biconvate uterus, they are further apart. That is why in case of a septate uterus, the interconval distance is less than 4 centimeter. Whereas in biconvate, the interconval distance is more than 4 centimeter. The next is the angle between them. As we already discussed, the angle which is there, it is more close by. That is, it is acute in case of a septate uterus. Whereas in case of biconvate, the angle is more obtuse. So this is how you basically differentiate between these images. Coming to the next question. So what do you see here? Again, this is an HSG image, yet another Mullerian anomaly is shown here. So you can see that there is just one part of the uterus which is seen, which is deviated to one side, and you can see the fallopian tube on only one side. This is basically the unicornuate uterus, and this sign is known as the banana sign. The banana sign is associated with unicornuate uterus. All right, so this is the unicornuate uterus. Now, this is a very important topic, often repeated. It has come for the NEET PG, NExT, FMGE multiple times. What do you see in this image? So this is basically an imperforate hymen. So you can see that there is a bulging bluish membrane. There is a membrane which is bulging and it is bluish in color. And typically in the history, the patient will say that, when we examine, we'll see that while the patient coughs, strains, or does any Valsalva maneuver, the bulge increases. And this is typical of an imperforate hymen. So let's see what are the clinical features apart from this the patient can have. So the patient can present with primary amenorrhea, that is, she has not attained her menarche yet. The patient can have a suprapubic bulge and a bulging bluish membrane. Why is there a suprapubic bulge? This is basically due to the collected blood in the vagina and uterus. When we do a suprapubic palpation, you can feel the bulge of the uterus. This is basically seen along with imperforate hymen. So the typical sign that you have to look for is the bulging bluish membrane, which increases in size on coughing and Valsalva as well as straining. So how will you manage this condition? Again, yet another very important question. So you have a hymen which has not yet perforated. So we can basically put an incision so as to drain out the blood which has collected inside. And this cross-shaped incision that I'm going to put here is known as the cruciate incision. So the management is cruciate incision. So again, imperforate hymen is a very important topic. So this is basically an outflow tract obstruction where the blood is not flowing out, due to which the patient has primary amenorrhea. As the blood is collected inside, the patient can have, there could be suprapubic bulge, the patient can have even retention of urine. When this enlarged uterus compresses on the urethra, the patient can present with retention of urine. What is the image that you see here? Here you will see that the bulge is not at the level of hymen, but slightly posterolateral part of vagina. And this is very characteristic of Bartholin cyst. So this is Bartholin cyst. And why does Bartholin cyst happen? So basically we have Bartholin glands, which is going to cause lubrication at the time of intercourse. And they have this Bartholin's duct. So any obstruction to the Bartholin's duct can lead to Bartholin's cyst, and sometimes even they can get infected. And this condition is known as Bartholin's abscess. This is known as Bartholin's abscess. So the most common cause of infection in Bartholin's abscess, again a previous year question, it is due to E. coli. It's not gonococci. Gonococci is the second most common cause. The most common cause is E. coli, followed by gonococcal infections. So this is yet another image of the Bartholin cyst. I hope here you can appreciate the bulge which is present, and you can see that it is slightly laterally and in the posterior part of the vagina. It is not anteriorly here. It's in the posterolateral wall. This is the Bartholin cyst. Whereas in case of Gardner's cyst, there is an anterolateral swelling which is present. So as I discussed, the Bartholin cyst is formed due to the obstruction of Bartholin's duct. And where does this Bartholin's duct open into? It's very important to understand that this Bartholin's duct is going to open at the junction between this labia minora and the hymen. So this is the opening of the Bartholin's duct. Now coming to the next question. So I have included some image-based questions as well, which is very important. So let me give you a clue. Both these instruments are used along with myomectomy or fibroid removal. So the first instrument that is shown here is the Boney's myomectomy clamp. So this Boney's myomectomy clamp is applied so as to obstruct the uterine artery so that we can decrease the blood flow to the uterus. So this is basically applied prior to the myomectomy so as to decrease the bleeding that is happening during myomectomy. The second instrument, what is the characteristic feature that you can see here? There is spiral grooves which is present, and this is basically introduced into the myoma so as to give a firm grip over the myoma so that we can enucleate the myoma or fibroid. And this is known as myoma screw. So the first instrument is Boney's myomectomy clamp and the second one is myoma screw. Now, let's discuss a bit about the vaginal cytology. So in vaginal cytology, there can be various different types of cells. The important cells are superficial, intermediate, and basal or parabasal cell. And these cells are going to differ depending on the hormone which is predominant at that time, whether it is estrogen, progesterone, or no hormones at all. So how do we differentiate each of these type of cells? The first cell that is shown is superficial cells. So superficial cells, as you can strikingly see from the image, it has a pink appearance. It has an eosinophilic cytoplasm. The borders are basically irregular and it has a very small nucleus. This is how the superficial cells appear. So you can see the irregular border which is there, the pink eosinophilic cytoplasm and the small nucleus. Whereas in case of an intermediate cell, as seen from the picture, again the borders are irregular, but the cytoplasm is blue or basophilic and the nucleus is slightly larger. Finally, coming to the last cell, which is the parabasal cell, you will see a round cell which has regular borders and a large regular nucleus as well. This is how you differentiate these three types of cells. Now let's go a bit forward and let's discuss the hormones, the main type of cell which is going to be present depending on the hormonal influence. If estrogen is the predominant hormone, the cells are going to be superficial type of cells. If progesterone is the predominant hormone, the main cells are going to be intermediate type of cells. If there is no hormonal influence, the cells are going to be parabasal cells. So in pregnancy, what would be the main type of cell seen? In pregnancy, the main hormone is progesterone. That is why in pregnancy, the main type of cell is intermediate cell. What about a postmenopausal female where there is not much hormonal influence? I told you if there is no hormonal influence, it is going to be parabasal type of cells. So in postmenopausal female, it is going to be the parabasal type of cells. Okay, so this is basically the visual inspection methods that is used for cervical screening. So here I have shown you two tests, that is VIA, that is visual inspection with acetic acid, and VILI, that is visual inspection with Lugol's iodine. So in the first image, if you see here, you can see some white areas after VIA. So can you appreciate these white areas? These are basically the aceto-white areas. And it is the abnormal cells which become or take up these aceto-white stain. And this is the abnormal areas that appear as aceto-white. So please note that in case of VIA, visual inspection with acetic acid, it is the abnormal areas that take up the white color. In contrast to this, in case of a villi, which is visual inspection with Lugol's iodine, when we apply this Lugol's iodine, The normal areas take up the dense brown color and they appear as mahogany brown in color. So the first image is the normal areas which appear as brown. Whereas the second image is the abnormal areas which do not take up these color. Why is there a disparity here? Why does the normal areas take up these dense brown color? This is basically due to the glycogen which is present in the cells. Due to the glycogen content which is there, the cells are going to take up the iodine. Whereas these abnormal areas which has high mitotic activity will have less glycogen content. As there is less glycogen, there is less take up of the dye as well. And they appear as yellow areas. Coming to the next image here. Can you identify what is the gross histology which is shown here? So this is basically a cut section of the uterus. So here you can see the uterine musculature and the small cervix which is at the end. What is striking about this image? The uterus is enlarged, it is globular, and you can see these brown cystic areas which is present. This appearance is characteristic of adenomyosis. So let's understand what happens in adenomyosis. Why is there these brown areas which is cystic? So basically in adenomyosis, there are these endometrial glands which are present in the muscular layer or the musculature of the uterus. So there is presence of endometrial glands in the muscular layer, the myometrium of the uterus. And due to this, the uterus is uniformly enlarged. This uniform globular enlargement of the uterus helps us to differentiate this condition from a fibroid uterus. Even in fibroid uterus, you can have an enlarged uterus. But what happens in fibroid? It is usually irregularly enlarged. You can see a bossellated appearance which is associated with this. Now, as we discussed, the uterus is globular and uniformly enlarged. The investigation of choice, usually in cases where the ultrasound is inconclusive, we go for an MRI for confirming the diagnosis. So the gold standard investigation, if they ask you what is the gold standard investigation, it is histopathology. That is basically after examining it in the microscope, we have to see this endometrial glands which is present in the myometrium. Again, this is a pictorial representation of what you are going to see in histology as well. So adenomyosis, yes, again, a very important topic. There have been various clinical scenarios on this topic, an image-based question from this topic, and a very frequently asked question as well. Coming to the next type. This is basically showing you the various types of hymen. So again, we have seen the imperforate hymen previously. So this is basically imperforate hymen. Rather than this, they're going to show you something like bulging bluish membrane, which we showed previously. Sometimes there can be a very small opening which is present. This is basically an annular hymen. If you see a partition or a septa which is present in the hymenal opening, it is suggestive of a septate uterus. It is septate uterus. If there are small sieves or pores which is present in the hymen, rather than having a single opening, there is something like a sieve or small holes which are present. This is suggestive of a cribriform hymen. And finally, the last image is a pares introitus, where the hymen is, when the introitus itself is enlarged. There is a pares introitus and hymen, which is seen in the last image. So what is the cells that you see here? These are basically vaginal epithelial cells that are studded with bacteria. And these cells are known as clue cells. These are known as clue cells. Where do you see clue cells? In which vaginal infection can you appreciate these clue cells? They are basically seen in bacterial vaginosis. So bacterial vaginosis, you can see these clue cells. Please have a note of this image as well. So in case of bacterial vaginosis, other important features include the patient can have a fishy odor of vagina. In the vagina, there can be a fishy odor, and on adding KOH, there can be an ammoniacal smell, that is positive amine test or a positive whiff test. So these are some other important features that is associated with bacterial vaginosis. And in case of bacterial vaginosis, the pH is usually more than 4.5. So as you know, the pH of the vagina is acidic. In this, it slightly shifts towards the more alkaline side. And in this condition, you can see a thin gray-white discharge that is there. Coming to the next image. So what is the striking features that you can see in this? So you can see cystic areas which are there, and you can appreciate the yellow content, which is basically sebum, the hair which is present, and even the cartilage. When you see a cyst like this, which has components from various things, it can be bone, teeth, sometimes the sebaceous material, there could be hair which is present, you should think about the dermoid cyst. So in case of dermoid cysts, there are components from the epidermis, from the mesoderm, so basically there are components from the ectoderm, mesoderm, and endoderm. That is why you can see components from like the teeth, the hair could be there, the sebum, there is components. So when you see such a varied appearance in a cyst, think about dermoid cyst. Some of the one-liners that is seen with dermoid is, this cyst is the most common GCT or the germ cell tumor. Among all the germ cell tumors, the most common GCT, and this is the most common tumor that is seen in pregnancy as well as reproductive age group. The most common tumor that is seen overall, that is, if I take all the age groups, that is basically going to be the epithelial ovarian tumors. Among that, it is serous type of epithelial ovarian tumors. But among the germ cell tumors, if you see which is the most common type, it is the dermoid cyst. This dermoid cyst is also known as mature cystic teratoma. It is also known as mature cystic teratoma. This is the most common ovarian tumor in the reproductive age group. It's the most common ovarian tumor in pregnancy. And this is the most common ovarian tumor to undergo torsion as well. So yes, it's the most common tumor to undergo torsion as well. Usually they are benign. Very rarely, only in 10% of the cases, they can have malignant transformation. And the malignant variety, usually the malignancy arises from a protuberance. It is known as Rokitansky protuberance. So what is the site from which this malignancy arises? It is usually from the Rokitansky protuberance. And the most common malignancy that is associated is squamous cell carcinoma. As we told, there is component from ectoderm, endoderm, mesoderm, and that is ectodermal component, or it is a squamous cell carcinoma, which is the most common carcinoma that is associated. Coming to yet another instrument-based question. A very commonly used instrument in the outpatient department as well. What you see here is SIMS, double-bladed posterior vaginal wall speculum. You can just remember it as SIMS speculum. So what is the use of this SIMS speculum? This is basically used to retract the vaginal walls so as to give us a clear view of the cervix so that we can carry out any procedures in that region. It helps us to visualize the vaginal walls as well as the cervix. So an important thing that is, I told you this is SIMS speculum. So basically you might have heard about this SIMS triad, which is there. So what are included in case of SIMS triad? So this is basically the Marian SIMS. And he had actually devised some few surgeries, some instruments, some positions, which are actually in his name itself. So this constitutes the SIMS triad. So let's see what are components of SIMS triad. So as we already discussed, one is SIMS speculum. Apart from this, we have SIMS position, and this is showing the SIMS position. Finally, for the VVF repair as well, there is a technique that is devised by Marion Sims. Coming to the next question, this instrument is basically used to do the HSG. What is the instrument that is shown? The characteristic feature is you can see the triangular end which has the spiral grooves which is present, and this basically sits inside the cervix. And this is the Leach-Wilkinson cannula. The purpose of the Leach-Wilkinson cannula, which we commonly use it for, is for HSG or hysterosalpingography. So when do you do an HSG? What is the ideal time to perform the HSG, and what is the dye that you're going to use? So again, in the first images, we have seen about an HSG. In HSG, the dye that we use is basically a radio opaque dye. That is why the cavity was appearing as white. That's why the tubes were appearing as white once the dye goes in. And the usually used radio opaque dye is urographin. And the ideal time to do the HSG is in the post-menstrual period, so that I can be sure that the patient is not pregnant and the endometrium is thinnest at this time. So I'm going to do the HSG in the post-menstrual period. And if I tell you a specific time, it is in day 7 to day 10. This is the time where we do the HSG. Coming to the next question. So this is basically showing a forceps, and the characteristic feature in this forceps is you can see a teeth. There is one teeth over one handle and two teeth over the other handle. So you can see something like this. So whenever you get a forceps, I want you to look at two things. First is about the tip. How does the tip appear? Second is about the lock and then the shape as well. So basically this has a lock and the tip is showing something which is interlocking. There are two teeth on one end and one teeth on the other end. And this is basically a Cocker's forceps. And this Cocker's forceps is used to do artificial rupture of membrane. That is ARM, or artificial rupture of membrane. That is basically to augment the liver. Coming to the next image. So what do you see here through the vagina? You can see something coming out. This is basically the cord. And someone is very gently pulling the cord, and there is one hand which is kept in the suprapubic region. This is basically showing you controlled cord traction. So in controlled cord traction, we very gently pull the cord. There should not be any undue traction. And along with that, there is another hand which is kept in the suprapubic region, so that the uterus does not invert and come out. This is known as controlled cord traction. And this controlled cord traction is a very important step in the active management of third stage of labor. So let's see what are the steps in active management of third stage of labor. What is the first and foremost thing that you're going to do in this condition? The first thing is give the patient uterotonics. Uterotonics are basically drugs that will contract the uterus, and the uterotonic of choice is going to be oxytocin. So oxytocin is given 10 units within 1 minute of delivery of the baby, and it is given as an intramuscular injection. So the first thing is uterotonics, that is oxytocin. The next step is controlled cord traction. Along with that, we go for a delayed cord clamping. It is delayed cord clamping followed by controlled cord traction. Please understand that early cord clamping is never done if everything goes well. Suppose if there is a fetal distress where the baby requires resuscitation, or the baby has some cardiac issues where we don't want the fetal heart to be overloaded. In these conditions only, that is, there are exceptions. In these exceptions, I might go for an early cord clamping. Except these, the dictum is delayed cord clamping. Very, very important. Often they ask you all the following are steps of active management of third stage of labor, except. And again, this image-based question has also come once previously in the previous year questions as well. So the FMGE exams. So the third and the final step is to assess for the uterine tone. That is, in the postpartum period, we have to be vigilant about the tone of the uterus. I will assess the tone every 15 minutes for 2 hours. So please note that previously uterine massage was a routine practice, but now that's not the case. Suppose the tone of the uterus is normal, you need not go for a uterine massage. Only and only if the tone is decreased, then you are going to go for a uterine massage. So the uterine massage is not routine as of now. So the first and the most important step is going to be uterotonics, where we will give oxytocin. Next is delayed cord clamping and controlled cord traction. Finally, it is just postpartum vigilance, where you assess for the tone of the uterus. These are basically steps of active management of third stage of labor. Coming to the next image, this is showing a Veress needle. And this Veress needle is basically used to create pneumoperitoneum. So in case of laparoscopy, we have very limited space to work with. So what we do is we insert these Veress needle, and I'm going to put inside a gas so as to inflate the abdomen, and I have more working space. And what is the gas which is most commonly instilled? Yes, it is carbon dioxide. So we put in a Veress needle, and I'm going to put in carbon dioxide so as to cause pneumoperitoneum. Again, please have a look at the tip of the Veress needle. You can see a very thin instrument. This is where we fold it in a pen folding manner, and we insert the Veress needle into the abdominal wall. Once it is inserted, we instill the carbon dioxide gas so as to cause the pneumoperitoneum. So the answer is already given in this. So what do you appreciate in this image? Again, this is a laparoscopic view. So in this, you can appreciate the fundus of the uterus, and you can see that there is a bulge which is present in the tube. This is basically showing an ectopic pregnancy. So let me ask, which side is right and which is left for this patient? What type of ectopic is it? Is it left-sided or a right-sided ectopic pregnancy, which is shown here? This is basically a left-sided ectopic. Please understand that I'm going to be looking at the uterus from above. I have inserted a scope like this, and I'm looking from above. So this side which is there on the left, so this is going to be the left of the patient, and this is the right side of the patient. So this is left-sided tubal ectopic, which is shown here. What is the most common site of ectopic? It is in the fallopian tube. What is the most common non-tubal site of ectopic after the fallopian tube? It is most commonly in the ovaries. In the fallopian tube, the most common site is ampulla followed by the isthmus. So the most common site is ampulla followed by the isthmus. And in ectopic, you see a triad. And this triad is basically the patient is going to complain of amenorrhea. That is, she has not had her periods for some time. She can have abdominal pain, and even vaginal bleeding can be associated. So if you see a patient who is having amenorrhea, there is abdominal pain, and sometimes even bleeding per vagina. This is the triad of ectopic. So what is the first thing that you are going to do? Many students have a misconception that I will directly jump for an ultrasound. But the first thing, a very simple investigation that you can do is do a urine pregnancy test. Just confirm whether she is pregnant or not. So the first investigation that I'm going to do is urine pregnancy test. The next investigation, yes, now you are correct. The next investigation is ultrasound. And among ultrasound, the best is transvaginal sonography. So in case of an ectopic, when in a scenario where you see that the patient is having amenorrhea, bleeding, PV pain, first do the urine pregnancy test, then look for the ultrasound where you rule out the ectopic pregnancy. But what is the gold standard investigation? Again, I have shown you the gold standard in the image itself. The gold standard is going to be our laparoscopy, where I can see, diagnose, and even treat in the same setting. The gold standard is laparoscopy. So coming to the next image. So this is an ultrasound which is shown here. This is a transvaginal sonography. And in this, you can see that there are cystic areas which is present. You can see multiple cystic areas. And this is known as snowstorm appearance. This appearance is known as snowstorm appearance. And this is characteristic of a molar pregnancy, also known as Hydatidiform mole. It is associated with molar pregnancy or a Hydatidiform mole. This appearance, as I discussed, is snowstorm appearance. Again, molar pregnancy can be divided as we have the complete mole, partial mole, and it is a complete mole which has this diffuse villous edema and hydropic degeneration. The snowstorm appearance, this huge areas, that is profuse cystic areas, are basically associated with the complete mole. Whereas in case of a partial mole, there might be some fetal tissues as well. So if you see any form of fetal tissue, such as it could be, they can mention fetal RBCs, fetal decidua, fetal parts, anything like that, you will think about partial mole. Whereas snowstorm appearance is usually associated with complete mole. Coming to the next image, if you see here again, this is an ultrasound image and you can see the bulging eyes which is staring at you. And the head is ending very sharply, something like a frog eye appearance. This frog eye appearance, and also you can see that the cranial vault is actually very flat. There is no cranial vault as such. This is basically condition known as Anencephaly. This is Anencephaly. And the appearance, basically there is absent cranial bones. Along with that, there is a bulging orbit which is known as the frog eye appearance. So here the diagnosis is Anencephaly. Now let's discuss three very important CTG pictures. So what is CTG? They are basically cardiotocography. What is the difference between this CTG and NST? Very often we say it is CTG, it is NST, and many times even interchangeably as well. What's the basic difference between them? So in CTG, as the name suggests, it is cardiotocography. Toco means contraction. Cardio means I'm going to assess for the fetal heart rate. So if you see a graph in which there are two graphs, so as of here, you can see there are two graphs. One is basically tracing the fetal heart rate and the other is tracing the toco or the contractions of the uterus. Now we will understand that it is a CTG, that is a cardiotocography and not an NST. So in case of CTG, we look at various features like what is the baseline heart rate, what is the variability, is there any decelerations or the presence of any accelerations. So this image is basically showing you some decelerations. Decelerations are basically fall in the fetal heart rate below the baseline. Usually they can be from 10 to 15 beats. So when you see such a CTG, I want you to look at the contractions. When you see something like a mirror image, that is, here you can see a deceleration at dip, and it is just the perfect mirror image of the contraction which is happening here. Now you will think about early deceleration. Something which is appearing as a mirror image, it is early deceleration. That means the onset of the contraction is corresponding to the onset of deceleration. The peak of contraction is corresponding to the nadir of deceleration, and the ending of contraction corresponds to the end of the deceleration. Mirror image, early deceleration. And where is this early deceleration typically seen? They are associated with head compression. They are associated with head compression. Yes. Now again, there are two more decelerations that are shown here. If you look at this CTG, you will see that yes, there are decelerations and there is contraction. But they are not just mirror images. There is a phase shift. Once the contraction starts, the deceleration has not started. By the time the contraction peaks, the deceleration has started. Even after the contractions have ended, still the decelerations have not ended. It's only after that the decelerations end, later after the contraction has ended. So there is a phase shift. So when you see a CTG where there is phase shift, you will think about late decelerations. The decelerations are basically late. They have not come along with the contractions which are present. And these late decelerations are characteristics of uteroplacental insufficiency. So first I told you about early deceleration. Just remember mirror image. They are seen in head compression. Next is late deceleration where there is a phase shift. And these late decelerations are associated with placental, uteroplacental insufficiency. Finally, you have a situation where it is no relation between the decelerations and the contractions. These are basically varying and they are known as variable deceleration. And these variable decelerations are associated with cord compression. They are associated with cord compression. Yes. Coming to the next image. So this is the final question. So what is the conjugate that you can appreciate here? In the inlet, we have anteroposterior diameters. And among these anteroposterior diameter, there is only one diameter which can be clinically measured. What is that diameter which is shown in this image? So in this image, basically, I'm going to measure the distance which is from below the pubic symphysis till the sacral promontory. Again, anteroposterior diameters has been divided as three. You have the true conjugate, obstructive conjugate, and the diagonal conjugate. Let me tell you about these a bit more. So just remember the mnemonic Todd. So as to remember this, toddler, you can just connect as toddler or just remember Todd. So true is the uppermost one, which is from the upper border of pubic symphysis to the sacral promontory. Obstructive is from the most prominent part of the pubic symphysis, that is from the midpoint or the most prominent part to the sacral promontory. Finally, from the lower part of the sacral promontory to the lower part of the pubic symphysis to the sacral promontory, you have the diagonal conjugate. So these are the three conjugates which are associated. So now you might have realized that the diagonal which I showed was the lowermost one from the lower part of the pubic symphysis to the sacral promontory, and it is the diagonal conjugate which is shown. The importance is that the clinically measured conjugate is diagonal conjugate. So we measure diagonal conjugate, and so as to get the obstructive conjugate, we have to subtract 1.5 to 2 centimeter. So obstructive conjugate is diagonal conjugate minus 1.5. Even some sources have written it as 2 centimeter. Usually this diagonal conjugate is nearly 12 centimeter. And the obstructive conjugate is 10 to 10.5 centimeter. Now finally the topmost one, the topmost is true conjugate, also known as anatomical conjugate. So as to derive what the anatomical conjugate is, it is diagonal conjugate minus 1. And usually, so this is true conjugate, which is diagonal conjugate minus 1, and it is usually 11 centimeters. These are the various anteroposterior diameters. So again, this has been asked, this image from the upper border of pubic symphysis to sacral promontory, again a previous year question. What is the most significant conjugate among these three anteroposterior? It is the obstetric conjugate. Whichever is the shortest has more obstetric significance. The most significant one is the obstetric conjugate. How do you calculate the obstetric conjugate? It is diagonal. It is the diagonal conjugate minus 1.5 to 2 centimeter, and it's usually 10 to 10.5 centimeter. So let's just have again a look at the image. So if you get an image-based question like this is basically the obstetric conjugate which is shown here. Now let's have a look at the questions. Is it clear? So these are some of the very important questions that's from ObGyn. So please revise and go through it as well. If you have any doubts, you can ask me. All right, so best of luck for your exams as well. If you have any doubts or queries, you can contact me or message me as well. Best of luck for the exam, and let's conclude the session. So I got a query, that is, what is, you mean DOA or TOD? Did you mean the short form which I had written here, that is TOD? It is true, obstructive, and the diagonal conjugate. The true conjugate, obstructive conjugate, and the diagonal conjugate. True is also known as anatomical conjugate. True is also known as anatomical conjugate. All right. So that's all in this session. Thank you.